Good morning, everybody. Thank you for joining us and welcome. My name is Angeline Webb. I am the president of the Alberta Public Health Association, and I will be your moderator today. Thank you for joining us for the session on immunization in Alberta, understanding vaccine hesitancy and misinformation. Today, I'd just like to open now with a territorial acknowledgement. I know we are all joining from different parts of Alberta and the rest of Canada, but I will offer a land acknowledgement from where I'm speaking from today. With gratitude, I acknowledge that the land on which I live is Awiskwachewaskai or the City of Edmonton, located on Treaty 6 territory and within the Métis homeland and Métis region of Alberta. Métis Nation of Alberta Region 4, I acknowledge this land as the territory of diverse First Nations, including Cree, Dene, Nakota Sioux, Saulteaux, and Blackfoot. I am privileged to live, work, and breathe on this land, and I respect the sovereignty, lands, histories, language, knowledge systems, and cultures of all First Nations, Métis settlements, and Inuit communities and nations. I thank all Indigenous people for nurturing and protecting this land, and for enriching our shared heritage with their languages and cultures. Like I said, our session today is on immunization in Alberta, understanding vaccine hesitancy and misinformation. This session is part of the Immunization in Alberta webinar series presented by the Public Health Agency of Canada, the O'Brien Institute for Public Health, and the Alberta Public Health Association. We are hosting this series because Alberta is experiencing declining immunization rates, increasing misinformation, and an ongoing measles outbreak. At the same time, Alberta's population continues to grow. The Alberta Public Health Association has identified immunization advocacy as its top priority, and this series brings together public health, academic, and community voices to respond to that need. This is the third of 4 sessions in this series. Session 1 focused on the future of vaccination for public health. Session 2 examined equity-focused community engagement. Today, we turn specifically to vaccine hesitancy and misinformation. And our final session on March 18th will focus on immunization advocacy and policy recommendations, and we will share more details on that session soon. So vaccine hesitancy and misinformation continues to influence immunization decisions across Alberta, but hesitancy does not exist in isolation. It intersects with access barriers, trust, lived experience, and communication. Today's panel draws on population level data, outbreak trends, community experience, and clinical practice. We've structured the presentations to move from system-level drivers to coverage data and outbreak context to lived experience, and finally to clinical communication and practice tools. I will introduce our speakers, and then our speakers will each provide a short presentation. We will then take questions during a discussion period, which follows the presentations. So please use the Q&A functions to submit your questions. I would now like to introduce our speakers. Our first speaker is Dr. Shannon McDonald. Shannon is a professor of nursing at the University of Alberta, Tier 2 Canada Research Chair in Applied Pediatric Immunization, and lead Applied Immunization Research Program. Shannon's research focuses on identifying and addressing system-level barriers and supports to achieving high vaccine uptake in underserved populations. Her work integrates epidemiological and social science approaches and directly informs immunization policy and practice. Dr. Alison Galvez joined Alberta Health Services South Zone as a medical officer of health in 2021. Her current role is the MOH for Alberta's South Zone, working in the Ministry of Primary and Preventative Health Services in the Office of the Chief Medical Officer of Health. Our third speaker is Tina Magnuson. Tina was born in a low German Mennonite community in Mexico and later settled in Alberta. Tina has spent over a decade as a community health representative, bridging gaps between service providers and the low German-speaking Mennonite community. Today, she works with the Healthier Together initiative, where she uses her experience to create practical health resources for the low German Mennonite community. She organizes local events and helps service providers understand the culture. Dr. Constantine Nescu is a pediatrician, infectious disease specialist and clinical associate professor at the Cummings School of Medicine at U of C. Cora is a co-chair of Immunize Canada with firsthand experience addressing vaccine hesitancy at the clinic at Alberta Children's Hospital. She is deeply committed to advancing vaccine research and education. Her academic work focuses on vaccine acceptance and surveillance. Now I'll hand it over to Shannon for her presentation. Over to you, Shannon.
Great, thank you. Thanks for the opportunity to share a few opening thoughts about vaccine hesitancy and access as we get started. So first, about vaccine hesitancy. So vaccine hesitancy is a term that we've all heard, we've probably all used, but it's often conflated with the term vaccine uptake. And I would just want to sort of clarify those two terms. So while vaccine uptake is the actual behavior of receiving a vaccine hesitancy is an attitude or motivational state of being conflicted about or opposed to getting vaccinated. So someone can be vaccine hesitant and still get vaccinated, and someone can be unvaccinated for some reason that has nothing to do with vaccine hesitancy. So where does access come in? Access can also be referred to as practical barriers, and practical barriers are often systemic or structural barriers. Next slide, please. Here I'm showing a framework developed by the World Health Organization in 2022 that shows the behavioral and social drivers of vaccine uptake. So vaccine uptake, that gray box on the right, is partly influenced by an individual's motivation to be vaccinated, the pink box, which is in turn driven by their individual perception of the risk and benefits of being vaccinated and the social pressures that influence them. But vaccine uptake is also strongly influenced by practical issues, the blue box, particularly barriers resulting from system level or structural barriers to access. So this model may not be as familiar to you as the 3Cs model that many of us have been using. And that older model suggested that complacency, confidence, and convenience drive vaccine hesitancy. So that the outcome of that model is vaccine hesitancy. And this newer model really does a better job of depicting the relationship between vaccine hesitancy and vaccine uptake. As you'll see from the figure, practical issues don't necessarily act directly on vaccine uptake, but rather on the path from motivation to uptake. And in fact, I would argue that practical issues can act directly on the individual and social processes that influence the motivation to get vaccinated. So if you could just click once more on the slides to show that. Perfect. So I'm just going to share one example. So let's take the availability of a vaccination service. Imagine a parent who's being told by a healthcare provider that they trust that there's a measles outbreak in their community. And so it's important that their 8-month-old infant receives an early dose of MMR vaccine to protect them. So that parent calls the local public health clinic, only to be told that the next available appointment is in 6 weeks. It's not inconceivable that that parent who did what was asked of them by a healthcare provider they trusted begins to ask questions like, maybe the disease isn't really as bad as they say, or they would have got my child in the clinic faster. Or maybe they begin to question the recommendation they received from that trusted healthcare provider. So these individual and social processes then feed into their motivation to receive this vaccine and perhaps future vaccines as well. And the same issues can arise when at-risk populations can't access a service or are treated in a discriminatory way when they do try to access the service. So these access issues are really factors that each of us that works in vaccine practice, programs, and policy need to think about before we judge people too harshly for being vaccine hesitant or being unvaccinated. So understanding how access and hesitancy interact at a systems level is essential, and Alison will now show us how those dynamics appear in real-world coverage data and recent outbreaks. So I'll pass it over to Alison.
Good morning, everyone. I'm Alison Gonzalez. I am one of the medical officers of health working for South Zone here in Alberta. South Zone covers the portion of southern Alberta that extends south of Calgary to the US, east to Saskatchewan, and west to the Rockies. It includes larger cities like Lethbridge and Medicine Hat, and also smaller communities. This presentation will focus on data from the interactive health data application related to pertussis-containing vaccine and MMR vaccine in the South Zone. As you will see, when immunization coverage dips below protective levels, outbreaks become more likely. Next slide, please. This slide shows pertussis-containing vaccine coverage in the South Zone from 2018 to 2024, broken down by dose and age. You can see that there are 7 clusters of bars, with each cluster representing 1 year, from 2018 to 2024. Within each cluster, the bars show coverage for 4 early childhood doses and a school-age booster. Specifically, the doses are DTaP IPV Hib dose 1, 2, 3, and 4, all by age 2, and Tdap IPV by age 7. You can see the highest coverage is consistently for dose 1, which is the dark blue bar in each of the clusters, indicating that clients are generally accessing the system initially. Coverage then drops with subsequent doses, with the largest gap seen for dose 4, which is the light blue bar. There is a bump in coverage with the Tdap booster, which is the purple bar, compared with dose 4, which is the previous light blue bar, indicating that the school immunization program does help to boost coverage. The graph points towards increasing vulnerability to pertussis outbreaks, in particular among children who start but do not complete the series. Next slide, please. This slide shows MMR vaccine coverage in South Zone from 2018 to 2024, broken down by dose. Each cluster of bars represents a year, again, from 2018 to 2024. Within each cluster, the blue bar represents MMR dose 1 by age 2, and the orange bar represents MMR dose 2 by age 7. From 2018 to 2020, that's the first 3 clustered sets of bars, coverage for both dose 1 and dose 2 was relatively stable at around 80%. Starting in 2021, we generally start to see a decline in coverage for both doses, which continues through 2024. Additionally, the coverage levels are well below the 95% measles herd immunity threshold. Now, while data helps us see patterns and risks, behind those numbers are communities and lived experiences. And next up, Tina will help us understand that perspective more deeply.
Good morning, everybody. As mentioned, my name is Tina Megason, and in my current role as a community health representative, and for over a decade, I have focused on supporting families in rural, faith-based, and culturally diverse low German Mennonite communities in southern Alberta. So I bring lived experience to this work, having grown up in that same culture and encountering many of the same access, trust, and communication barriers we work to bridge today. That perspective shapes how I listen, how I communicate, and how I approach sensitive conversations like vaccines. Much of our work involves helping families navigate the Alberta healthcare system. So things like finding accurate information, overcoming language or literacy barriers, and rebuilding trust when past experiences have not been positive. Negative experiences from other countries can also create barriers here in Alberta and require a relationship building to address. Health decisions are not made in isolation. They are influenced by family, faith, community, history, and of course, lived experience. Our approach is always relationship-based and trust-focused. As I've listened to some of the other presenters in this series, I've noticed many similar themes emerging, which is encouraging because it shows we're starting to get on the same page. Vaccine hesitancy is not unique to any one group. It appears across cultures, education levels, and both urban and rural settings. However, it does become more complex when multiple barriers exist and providers are unaware of these barriers. In some cases, mistrust stems from generational experiences with government or healthcare systems and was, of course, reinforced during COVID. Families sometimes express broader societal concerns, such as fears about control, profit, or population impact. While these beliefs may be shaped by misinformation or past experiences, they are real to the person expressing them. Approaching these conversations with curiosity, clear information, and respect helps maintain that connection. Barriers can include access issues such as technology challenges or complicated phone systems, language barriers, health literacy, and then deeply held values around family, faith, and autonomy. Misinformation does circulate quietly through family or social networks, including fears about autism or ethical concerns around vaccine development. And occasionally, people express a more resigned or faith-based view of illness, which can influence how prevention messaging is received. Ingredient concerns also arise frequently. Many families feel comfortable using medications, but feel uncertain about vaccine ingredients due to the information they have encountered. These concerns rarely come from opposition. More often, they come from a desire to protect their children while navigating overwhelming and conflicting information. Another barrier is limited familiarity with what certain immunizations are for or how they work. Some families believe that if disease appear rare or herd immunity exists, then vaccination may no longer be necessary. Many people have never seen the long-term consequences of these illnesses, like measles or mumps, so the risk can feel theoretical. Some even believe diseases have fewer long-term effects than the vaccines themselves. And this highlights the need for simple, transparent education and better resources explaining how vaccines work and why recommendations remain important. Next slide, please. So since COVID, some individuals feel hesitant about contact tracing as well, or identifying close contacts. So we've been part of those phone calls when there's a language barrier to talk about a measles case. And it's not because they don't care about health, but because they want to protect relationships and avoid bringing attention to others. Acknowledging those concerns and clearly explaining the purpose and limits of public health processes definitely helps rebuild that trust and engagement, which we're all working to do. What consistently makes the biggest difference in our experience is listening. When people feel heard and not judged, that trust can grow, allowing meaningful conversations and opportunities to share factual information. Many families have heard terrifying stories about vaccine side effects and need space to voice those concerns. So hearing them out, finding out where they're coming from, because hesitancy, again, does not always mean anti-science. Most people value their health and evidence, but want to feel safe, informed, and respected. So from a community health perspective, our role is not to force decisions, but to support informed choice through culturally aware, relationship-centered care. Again, we want that informed choice to happen. We want families to be able to ask the questions that they need to and feel safe making those decisions. Community experience shows us how trust and communication shape decisions, and Cora will now speak to how clinicians can approach vaccine hesitancy in practice.
Thank you very much, Tina, and thank you to the organizers for having me at this session. Since vaccine hesitancy has become such a hot topic, I think it's almost inevitable that as a healthcare provider, you're going to come across this conversation either in clinical practice or in your personal lives. So the next few slides are supposed to help and maybe give you a few resources on how you can address that in a one-to-one type of interaction. And the exciting part about vaccine hesitancy, the maybe really only exciting part has been that even though it has increased since COVID and the pandemic, and even though vaccine resistance has quadrupled since then, healthcare workers are still the most trusted source of vaccine information for our patients. And that's incredibly powerful to think about. And here's what else is exciting about this. We know from the research we did on our vaccine hesitant patients in our clinic that a big facilitator for vaccine uptake is having a positive interaction in a healthcare setting. And that has nothing to do with vaccines. So, for example, often a lot of my colleagues will say, well, I don't have the time and the resources or even the information and the knowledge to hold the full vaccine hesitancy conversation. But really, all you need to focus on is having a positive interaction, which means patients feel heard, they feel respected and cared for, and that alone is a facilitator for behavioral change and vaccine uptake later on. Next slide, please. And if you're going to look at the crux of vaccine hesitancy is very heterogeneous, as Tina and other speakers mentioned, and it's very different across cultures and communities and age groups. But if you're going to look at the crux of it, it really comes down to this distrustful complacency. It's this combination of low concern for the disease and low trust in the healthcare system or in the vaccines or vaccine manufacturers themselves. Next slide, please. So I've tried to pick what I thought were common features that work across vaccine hesitancy patients. And I apologize about the fact that am I the only one? Oh no, it's all sorry, I thought my slide was cut off. So across different areas and across different populations of vaccine hesitancy, these are the features that I have seen and also the literature supports that are common when it comes to addressing this. Again, in a one-to-one, this is a bit different than, building a mass campaign, but in one-to-one conversation, the first step is finding common ground. And I can't say that enough. And for me, I'll give you examples of how I do that. Often when I see somebody for vaccine hesitancy in clinic, I'll start doing a short history. I'll ask them about their child, about their family, about their travel plans. And as you learn more about them, try to connect with them. So before you can communicate vaccine information, try to find some connection. And for me, often it is they don't like antibiotics. I don't like antibiotics, even though I'm an infectious disease physician. People may talk about, healthy diets and choices. They talk about how to build a healthy gut. I'm all about fermentation, not about raw milk. Don't recommend that. And reducing sugar. So they can be things that you can talk about that in some way, you can connect with that family, so they feel that there is a bit of common ground, and that they can then trust what you are about to say from a vaccine perspective. And the next step is showing true curiosity and fighting the urge to correct and judge. And I tell you, I find this is a really hard one. I jokingly say there's nothing new under the sun. Every vaccine, I have yet to find something truly new in terms of vaccine hesitancy. So it's hard to sometimes maintain curiosity, but just remember that to that family, it's different and it's new to them. And I often acknowledge what we have in common. And that may be being parents or caring about um, community or caring about immune system. Acknowledge what you have in common with them. And the next step is validating the emotion. And I can't say this enough. People come at this often from a place of fear or anxiety and genuine worry. By the time they're actually talking to you about this, these are people who want those worries and those fears heard and validated. They want to hear that it's okay, and you hear that they are truly anxious and worried about this. And a new thing that I have noticed, and I haven't seen this supported much in the literature, but I've noticed a lot about this, is that newer parents, maybe in the last decade or so, associate questioning science and questioning decisions with being better parents. And I say that's important to validate that they are trying to be really good parents, because most of them do. They want to make the best decision they can for their kid. And I often will also tell them what won't change. So I'll say, we'll talk a lot about vaccines and we'll talk a lot about choices and making decisions. But at the end of the day, you're still going to be the one who's going to make the decision for your child. And I want you to know that and take comfort in knowing that. And then when it comes to actually communicating around the vaccines, keep it personal. It's really tough. It's hard not to talk about politics, not talk about the pandemic. Don't talk about COVID unless it actually relates to that interaction. Keep it personal. Share your reasons and see if they apply to them, to that family, and really focus on the disease we're trying to prevent. You may not know everything about the vaccine, but we do notice that complacency, this low complacency, the sense that my child is not at risk of the disease, is a big driver for vaccination behavior. So focusing on the disease within the context of the family makes a difference. And speak with compassion, but also confidence. And I think that's important for people to know that your stance is one of pro-vaccine. You're there to help them make a decision to vaccinate their child, and that's okay to make that kind of take that presumptive approach. Next slide, please. This is just a simplified slide of what we talked about: connecting before communicating, showing that true curiosity, validating the emotion, and keeping it personal. Next slide. I do want to share with you a resource that we have developed with the support of the Public Health Agency of Canada Immunization Partnership Fund. This is publicly available on the Department of Pediatrics website. It's called our Vaccine Confidence Toolkit. Next slide, please. And we have ways to get into this for pediatrics, patients who are pregnant, or patients with immunocompromised. Next slide. And we have some really interesting new approaches at such as virtual simulation games specifically tailored to vaccine hesitancy communication. And I really want to draw your attention to the second one here, managing difficult conversation about vaccine refusal. For those of you who are in public health, those of you who do actually see patients who outright refuse vaccines, that can be very morally distressing to us as healthcare providers. And this virtual simulation game is specifically on how we can manage our own emotions and still stay connected and caring about our patients in the face of that. Thank you very much.
Thank you so much to all of our panelists. I would just like to begin our discussion period now, and just a reminder to everybody to put their questions in the Q&A function. I would just like to start with a bit of a broad question for all of our panelists. When you think about vaccine hesitancy in Alberta today, what do you see as the most misunderstood driver? And that's for all of our panelists. Whoever would like to speak up first, that would be great.
I don't mind going first, just in the order we spoke. I mean, my answer might sound obvious given what I just spoke about, but I think the system level drivers are often ignored. So how do structures and systems influence people's hesitancy? And, you know, I have seen vaccine hesitancy sort of treated like the scapegoat for, you know, the reason why people don't get vaccinated is vaccine hesitancy, and people just jump to that. So I think we always have to think about the context in which people are making decisions before we dive to that as you know, blaming the person who is hesitant.
Thank you, Shannon. Any other panelist?
I think that there's a lot of mistrust of expert institutions, and unfortunately, advice is often viewed skeptically, and that's not necessarily a bad thing. It's good to ask questions, but when the information source is questioned as, you know, potentially not having the right information or the wrong information, that's an issue. And I think that we need credible, trusted health messengers that people trust to help alleviate that discomfort that people are having with institutions.
And in our role as CHRs, we do try to be that trusted person for our community to reach out to when they have questions, because we do see that a lot of families are trying to make thoughtful decisions while navigating lots of mixed messaging. Like there's a lot of information out there, and for those that do speak enough English to start Googling things, they're not necessarily going to find helpful things. And so I believe that we need to have more messaging that is clear, that and helps families understand the risk of disease, so that they're not so worried about the vaccine side effects, essentially, so that there's more information to make these informed decisions in a language that everybody can understand, for each community separately if need be. And then, of course, with the experiences through COVID and some perceptions of vaccines not being effective, I think there again needs to be more information around the efficacy of the vaccines.
Thank you, Tina. Cora?
It's really interesting hearing everybody answer this, actually. You can see why you did well picking different people together. I think it makes a really strong, well-grounded type of approach. I tell you, I think we do need to normalize vaccine hesitancy to some extent in the vaccine discussion, and we need to just make it part of health discussions, the way we make preventative care in so many ways. But back to your question. In Alberta, I see a lot of individual agency and a lot more developed individual agency than probably in other parts. And it's a good thing. It's part of what makes Alberta so innovative and driven in so many ways, but there is a bit of loss of collective responsibility. And I'm not saying this is a bad thing, but there's a way to understand that when we build mass campaigns around immunization, if we build them around collective responsibility, it's not going to resonate with a lot of people in our province, whereas individual agency in the sense of individual protection actually might. Obviously, that does not apply to every community, but through the pandemic, we learned a lot about that, about individual agency being very well developed in our province. And I think when people have that, they do minimize the disease risk and they do um, uh, uh, maximize the vaccine side effects and fear of vaccines. And I think it does play into that to some extent. But I think it's important to acknowledge that and to see it. Now, why we have so much individual agency has its own research area. But I think we need to recognize that and see it and actually address that. And it goes back to what Shannon was saying, that has played into the whole idea of resources and structured and systems, and what Allison was saying about having the trusted sources, and it all plays together. But I see a lot of that in our province. It's probably a bit different than in other parts of Canada.
Great, thank you. And Cora, can you just indicate the site where the tools are again?
I did. I actually put it in the chat.
Oh, you did. Okay,
It's
perfect.
under answered.
Okay, thank you so much, Cora. We have another question here for all of our panelists. How can Alberta prepare for future vaccine rollouts or public health emergency? I think it's how can Alberta better prepare for vaccine rollouts?
I mean, I can start. I probably think the others might have some great ideas. I think it's about preparing is the right word. We just can't wait and respond. We need to build a strong foundation of obviously trust being a key driver, but also structures, that allow us to engage communities in future vaccine rollouts, so that we're not like building relationship on the fly, because relationship really is what drives trust. And the more we can have a strong foundation between, the broader systems, the healthcare providers, and the public, that'll stand us in good stead for whether it's a vaccine rollout or any kind of like emergency situation.
Great. Thank you, Shannon. Allison?
Yeah, definitely we need to be more proactive because we've had recurrent pertussis outbreaks. So in the last one in South Zone was in 2023 and it lasted over a year. Then we had one in 2017, 2015, 2014, 2012, 2009. Our measles outbreak started in March in 2025 and is ongoing. So we know that we need to be a little bit more proactive rather than reactive. And we know what the immunization rates are. We are hearing from families what their concerns are. So I think it's that question of communication messaging and ensuring that we're prepared for the next outbreak that comes down the line. But we do have a pattern here, and unfortunately, misinformation and mistrust is here, and we have to learn how to deal with it, especially in light of COVID. That definitely exacerbated things quite a bit. So I think that's that question of being more proactive with our communication messaging and anticipating what's coming down the pipeline. Thanks.
Thank you. Cora and Tina?
Yeah, I think just from our community health representative standpoint, having information that's understandable, that's plain language, that's and maybe for the different communities, that's in the languages that they best can understand things in, and making that information more readily available, as Allison said, before we have that emergency. Let's start building that up. Let's start making this information more accessible and at a level where everybody can understand it. It can be overwhelming as a parent to make the right decision. And when you're sifting through so much information that goes right over your head, or you just can't really understand what's being said, it's difficult to make that decision. And so if we can get that started now before we have any kind of emergent situation would be best.
I just want to say that the Pan American Health Organization has come up with some really nice pre-bunking and like is in think ahead of what when you come up with a new campaign or a new immunization rollout, think ahead of what some of the issues might be and address them. I can put the link in the chat because it's for managers and for healthcare workers. It's really a well done resource that I'm happy to share with people. Just working off of what Alison was saying about think ahead, and I totally actually need to think ahead about this. I also think we need a bit of a rapid response team on misinformation, especially with what's going on in the US and some of the stuff that's spilling over. Like it's almost like we have to think on our feet in terms of misinformation. But I'm also going to bring it back to the healthcare providers because I think in Alberta we really are, I'm going to say, very, very lucky and very fortunate in a lot of ways. So the fact that public health does all the delivery of the childhood routine vaccinations, that's a very strong, very strong point on our provincial side. And also we have a electronic registry, which is also very powerful when you think about that in terms of our surveillance and ability to know what our uptake is. But we often do forget about family physicians and pediatricians and nurse practitioners and all the people on the ground who are still going to be the ones who have to provide information. So I think maybe just a reminder that when we do those new rollouts and campaigns, we do have to remember the family physicians and those primary care providers who actually are still going to be at the forefront of vaccine hesitancy and providing information about any new rollouts. And we learned that the hard way, I think, a little bit with COVID. I mean, people tried very hard, but there was so much misinformation and conflicting information. It was hard for those people, the boots on the ground, to actually know how to address the patients they were seeing.
Great. Thank you, Cora, and all of our panelists. So on to our just next question. What are the recommendations on how to bridge the gaps for those who are in the pre-contemplative stage of change in regards to vaccine hesitancy? How do we reach those who may not even be willing to visit a healthcare professional? Maybe over to Tina. I think that might be, not to put you on the spot, Tina.
No, I think that and we're really lucky here in South Zone to have these positions, to be a community health rep working with this population, because there's a lot of barriers that our families experience that they would maybe never come in to see a healthcare provider if we weren't here to help them navigate the system. So I think finding out again who's in your areas, what's the community that you're serving, and what could the barriers be, and get somebody from within the community to start building some of those bridges so that the conversations can begin. There's opportunity in many different ways. One of the things that we've tried to do here is when we have events for our families, for our mums, is we invite out the public health nurses to come build relationship, to start building some of that trust, and to highlight some of the other services that they provide, that they're not just vaccine nurses. There are so many other services that our families can access. You can go weigh your baby whenever you want to see how they're coming along with their weight. You can come in for all kinds of advice. There's different programs for those that are low income. So I think there's opportunities all around. And if you're hosting events, if you're putting on programming, see if there's a way to invite some of the public health or other health professionals that can come out and just assist for the day. We're planning a mental health workshop in one of our communities, and we're looking to invite service providers that may be an access that our families can access, and then if they're at our event, building that relationship, I think that goes a long way. Again, trust and relationship is key. And if there are those that are on the fence or those that are not even looking at the fence, trust and relationship is key to start having these conversations.
Thanks, Tina. Any other panelists to add to that? No? Okay.
I'm just going
Oh,
to say
sorry,
one
Cora,
thing
go ahead.
about it's okay from a healthcare provider perspective. We've seen a number of families like this, and I'm sure a lot of those who do family medicine see a lot of them. And I say, just because they're resistant today does not mean they're always going to be resistant. And just always, like, the most important thing you can do is open the conversation. Open the conversation to say, hey, I noticed this. When can we sit down and talk about it? And then maybe they say never, and you just keep on asking this over and over. And one day they might change their minds, because vaccine hesitancy is all about the moment, and like it's about the historical moment that we're in, and people who were vaccine hesitant around measles did change their minds when the measles outbreak was happening. So I'm just saying, always keep that conversation still open. And back to this, hard not to judge, hard not to judge, but if we can just work on that every day, and as healthcare providers should do that, I think, with everything we do, then our patients know it. They know when we don't judge them and when we're truly open to them. They sense that, and one day they might open up. I know I'm always a pediatrician that's always optimistic about these things, but we just cannot give up just because they said no once.
Thank you, Cora. Just on to our next question. With the provincial government's more lax attitude towards vaccine uptake, how does political influence impact vaccine hesitancy individually and in communities? And what can researchers, clinicians, and community workers do to combat these issues?
That's a difficult question. So I can't speak for higher leadership, but I think that the importance is to have good communication with your communities and the boots on the ground, working on an individual level, community level. That's the most important thing right now. Would it be great to have more messaging? Absolutely. But barring that, we have to continue to do our work and build those trusting relationships and listen and have that curiosity for questions that families may have about vaccines, approaching it that way. And I think we'll make a lot of headway if we work on that particular level and ensuring that we're continuing to build on those trusted relationships. So great,
Yeah.
thank you, Allison.
I'll just quickly add, from a community standpoint, I think that the relationship between service providers here locally and the community is the more important one. If we can establish some really strong relationships and that trust can keep building, and we have bridges for the different communities that maybe wouldn't be able to access otherwise, and we remove some of the barriers that we can at a local level, it's going to be as effective as, or more effective than even from the political side of things, in my opinion.
Mhm. Thank you, Tina. Okay.
I have something to say about that.
Oh, okay. Go ahead, Cora.
So I do see this a lot, I think,
Mhm.
and there are now a number of polls that show this as well, that there is clearly a political bent to vaccine hesitancy and resistance. Um, I I think clinically, I think as healthcare providers, we have a lot to do to let our government know where we stand on these things, and whether that's via letters or whatever, that's different. But I think in one-to-one interactions, um, those are, I've learned, a bad thing to bring up. However, always talk about the disease. It doesn't matter what the government is measles. So bring up the disease awareness and how bad disease can be and what it can mean to their families, despite their political, measles does not care where your political stance is. It's going to affect and impact the same way. So I always, whenever I get into those, I remind myself this is not the place to go, but I can always talk about disease awareness.
Great. Oh, Shannon, go ahead.
Yeah, I'll just round it out by saying,
Mhm.
it's a nice I've heard this nice saying, which is people trust individuals, they don't trust institutions or organizations. And obviously it's a bit more nuanced than that, but it's about what the others have been saying, that regardless of what is going on at those higher levels, those of you that are at the front line, or people like myself, researchers, there's ways we can function that can support families in the decisions they're making, regardless of that.
That's great. Thank you, Shannon. Just on to our next question. So this is about access to primary care. Does Alberta have enough community care workers and family physicians to support those trusted relationships that everyone has been talking about? We know that 15% of Albertans are not attached to a physician, a primary care physician, and how do we overcome this gap to ensure that vaccine hesitancy is reduced and people have access to what they need to make informed decisions if those relationships are low or don't have access to those?
Yeah, it's a tricky one. I think the one answer to it is just any of us that are in a position where we're interacting with the public, whether or not it's our role to vaccinate or not, need to take advantage of those opportunities to open doors to conversations. And like those of you that are not healthcare providers or in any of these sorts of roles I've just described, just members of the public. If members of the public are more open about their choices to vaccinate, then there's that social norm message that gets out there. Like, I mean, when I'm at my kid's soccer game, I'm like, oh, got a sore arm. I just came from getting my flu shot, you know. We talk about it to try and normalize that vaccination is the social norm or should be the social norm.
Mhm. Thank you, Shannon. Any other comment on access to primary care, healthcare professionals in general?
It's not really what I can't advise on that. I think it's not enough, but I don't know how to fix that. I do know, though, that it seems to me, I see patients for vaccine hesitancy, and I tell you, it takes a good hour to talk to patients. And it's hard for me to imagine how any family physician can do that in the time constraints they have. And I think it's a bit unfair. Whenever, people come to me and say, talk to your doctor, I cringe a little because I think, oh my gosh, that physician was going to be faced with that. So I don't really think, I think whereas they do see a lot of it, I don't really think we can just say this is a family physician problem and they should solve it because it's terribly unfair. I do think it just speaks to, back to that idea of a rapid response and public health level type of campaigns and fighting misinformation on all those levels before we can just say this is a one-on-one conversation with your family physician as much as we're going to support them. And even if everybody did have a family physician, I still don't think it would be enough. And back to what Tina was saying about community supports and engaging, whether it's religious leaders and cultural leaders and vaccine champions within communities, all of that has to be done as opposed to leaving it to not that anyone does, but it's not just the family physicians who can fight this. Even though they are, I tell you, the most trusted source. Every poll shows that. So
Yeah, so it's about bona fide community engagement, that the health system isn't just the health is in community, not just the health system's responsibility. Over to you, Tina. I know that
okay.
this is probably important to you.
Yeah, I think that before anybody even goes to the doctor's office, most of us are checking out for information online. And even our community that might not be as digitally inclined as others, there's a thing called WhatsApp, and information is being shared. And there's lots of places that we could have opportunities of providing factual information that's digestible by these different communities. And so they may not have an hour with their family doctor, but if we could provide some resources that are plain language, that are easy to understand, that can maybe address some of the fears and anxiety that our moms and dads are facing with the decision to vaccinate, I think that'll go a long way. And of course, if there are community health reps or other community members that can assist with this on the ground level of creating something that is fully understood and reduces that anxiety. I feel like the anxiety for a parent in today's world of making this decision, when we were little, it wasn't really a thing. You just got vaccinated. It wasn't a debate. It wasn't a question. It was just a thing you did. And now in today's world, there's so much confusion around it. So if we could create some really good resources across all the different cultures, different languages, and have it really easy to digest, I think that will really help the physicians and other healthcare providers. And then it could be here, let me send you this link with this information, and then we can book a follow-up appointment to discuss or something to that end.
Great, thank you, Tina. This is a bit a broader question on research gaps. So in your opinion, What research gaps remain that should be explored to enhance vaccine uptake and community involvement? And this is a big question.
Oh
Cora.
my gosh, there are so many. Well,
Yeah.
thank you for asking this question. No, there's so many, but I'll tell you from Shannon is thinking about this all the time. You can see her like brain already going, but I'll tell you what I've noticed a lot from a pediatric perspective. Um, these diseases, it's really interesting looking at the measles outbreak. We're so fortunate that our mortality was nowhere near other outbreak mortalities, and even our hospitalization was not the same. As we don't like right now, just looking at it. And I think what we need to know, so for sure, people are not going to die of vaccine preventable diseases the same way that they died 50 or 60 years ago with with what we have right now. But I think to me, a misunderstanding is that, well, if my kid's not going to die, they just end up in hospital. That's not a big deal. So I'm really interested to see how hospitalization would impact parental decision making and how we can change uh, the conversation from talking about children dying to children being end up in hospital, parents losing time off of work, of their communities, the trauma that has on the family. And I think that's a little bit, it's starting to emerge as a research question, but I think we don't yet fully. And I think that's important because it will change impact of these vaccine preventable diseases on families. Because again, it really eats away at me when I see that people compare number of children dying to adults dying. Well, that's such a ridiculous comparison. Nobody would think that would be the same, and yet often that is how we offer epidemiological stats on vaccine preventable disease. And I think if we just think about how that impacts society, families, hospitalizations, to me, that's a huge gap that might change perception of these diseases.
Thank you, Cora.
I mean, as a vaccine researcher, I could like just talk forever about this, but I think in relation to the things we're talking about today, I think one of the areas, well, I guess two areas I'd love to see more research on is how else can we be reaching people with vaccinations? So as much as I absolutely love our public health clinic focused or school focused programs, I wonder if there's other places and potentially providers that could make it just easier for people. So I know that's an area that I do a lot of research in. And then in terms of community involvement, because that was part of the question, I hear about these great small scale pilot or intervention studies. For instance, like during the pandemic, the Métis Nation of Alberta offered a Métis COVID vaccination clinic. And in Muskogee, just south of Edmonton, they have this fantastic program with wraparound resources for families, but it's only for it's small numbers. And I just think there's a great opportunity to maybe study those initiatives and think about how we could scale them up, because you couldn't do it the way it's being done for like an entire community or an entire, city. But studying those initiatives, what was working about it and what could we scale up at, that's not going to be financially prohibitive. What can we learn from it and scale up? I would love to see more of that type of research.
Thank you. Tina, is there anything that you think is a gap from the community perspective, and which answers you would like to be answered? Which questions you would like to be answered?
Well, I think that for our community, having somebody to bridge some of those gaps is key. And we are there's a number of us now in this role, but I think there's always room for more. The community that we serve, there's pockets of our low German families all over Alberta, and so I think it would be good to have more resources for this community and other communities maybe that are experiencing multiple barriers. And so I think we have a lot of work to do and maybe not enough resources to do it. And I love that we're doing this, that we're all talking together and working together to find the answers maybe that can address some of these situations. Not sure if that answers your question.
Thanks, Tina.
Mhm.
Just one last question. We do have a question regarding the announcement of the Alberta government looking at cutting health coverage for certain populations in Alberta. And the question is mostly around, what advocacy can be done, and does the Public Health Association have representation in the provincial government? I would suggest that if folks want to learn more about advocacy and policy recommendations with reference to how to do this work, particularly public health advocacy, to attend our March 18th webinar. So some of that would come out then. I just have one last question, and thank you for Frederick for asking that question. If practitioners listening today could change one thing in how they approach vaccine conversations or program delivery, what would you encourage them to focus on? And this is just for all of our panelists.
Maybe I'll start it off just because I feel like I kind of addressed it a little bit. I'm just going to leave two things. One is have the conversation, just open the conversation, allow them the space to know that it's a safe space with you. And then talk about the disease. You don't need to know everything about the vaccine. It's complex and I get it, but just talk about the disease and what you know about the disease and somehow help them see how that disease is a threat to their family.
Thank you.
I think mine would be to understand the context in which people are living before you start giving advice. So if somebody has no way to take time off work to get across town without a car to a scheduled appointment when they don't even know what their shifts are 2 weeks from now, those are problems that need to be addressed before you can move forward, really.
I would agree with Shannon. Find out what the barriers are and then see if you can remove some of those barriers, whether it's a language barrier, transportation barrier, use an interpreter if possible, but make sure it's somebody that's a professional interpreter and not a child or sometimes not even a spouse, depending on the situation, but making sure that you're sharing information the information that you're sharing is fully understood. And if you need to engage some sort of resource to make sure that that's happening, then do so. And sometimes that can take more time, but make sure that your message is being received and that they are able to voice their concerns fully.
I'd say to help foster a safe environment. So building on what Cora said, just so people feel like they can be heard and listened to. I think that's one of the most important things that can be brought about. Thanks.
Great. Thank you so much, everybody. Just one comment from in our Q&A, we just have a couple of suggestions, mostly from Pam, that has suggested that there needs to be more support for operational teams because they're the ones that are astute and aware of the vaccine messaging on an ongoing basis in community. Is there a suggestion from any of the panelists on how to improve support for those operational teams that are in community?
Well, as a community health rep, we are here to support with cultural information. If there are some barriers that we can remove with regard to language or just cultural understanding, and again, I'm just talking from one cultural community, but there are, I believe, others that could assist with other cultures in that regard too. So, my 2 cents.
Great, thank you so much. And I think we are mostly out of time today, but I would like to thank our panelists for their thoughtful contributions today and for sharing their expertise and experience with us. We also encourage everyone to take a few moments to complete the post-event survey. Your feedback helps us shape the remainder of this series and future sessions. Finally, a reminder that our 4th and final webinar in this series, Immunization Advocacy and Policy Recommendations, will take place on March 18th from 2 to 3 p.m. Mountain, and more details will be shared soon. Once again, I'd really like to thank our panelists and for everybody attending. We really appreciate everybody's interest in this important issue. Thank you, everybody, and we look forward to seeing everyone again on March 18th. Thank you.